Welcome to the Dr. Geo Prostate Podcast. Today's guest is Dr. Justin Dubin, a fellowship-trained urologist and andrologist at Memorial Healthcare System. He specializes in male fertility, low testosterone, Peyronie's disease, sexual function, and testicular pain, everything related to men's sexual and reproductive health. Dr. Dubin is also the host of Man Up, a Doctor's Guide to Men's Health. In this episode, Dr. Geo and Dr. Dubin explore the rise of direct-to-consumer testosterone clinics. They break down what these clinics get right, where they fall short, and why the buzzword optimization may not always serve patients well. You'll hear what every man should ask before starting TRT and how to make informed choices about your hormonal health. Let's get into it.
Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Geo Prostate Podcast. I'm your host, Dr. Geo, where it is my intention, my love, honestly, my passion to teach you everything I can with these great experts on prostate health and erections and male wellness, and of course, how to live better with age. With great pleasure, this is your second time around, Justin. Dr. Justin Dubin. Last episode was episode 77. And we talked a bit about male porn and the fact why male porn artists, men, just in case, suffer from ED, and that was a hit. And so people can refer to that again. And so thanks so much for being on again, Justin.
Thanks for having me on. This is really great. We were talking before here. I really appreciate you in the healthcare space, in the urology space, in the wellness space. Your curiosity is contagious, and I'm really always excited to come on. I love watching the episodes we were talking about. I was watching a couple of the recent episodes, so it's always great to come on. Thanks for having me.
Oh, man, thanks for those kind words. And yeah, we did chat for about 45 minutes before recording. It's always, again, it's always amazing speaking with you offline and at conferences. So Justin, one of the reasons here I am, you get the alerts of things that you're interested in. It's like some alert on testosterone clinics, and it was published in the Scientific America not that long ago. And I'm like, oh, let me take a look at this. I was like, oh, look who's quoted. My man, Justin Dubin. He's quoted in Scientific America. And I sent that to you, of course, and of course you knew about it. And the article was about, it started with a story of a man that was diagnosed with hypogonadal. He went to low testosterone, which is hypogonadal for the audience. And he goes to a male clinic, and it turned out that he didn't need testosterone. I'm kind of summarizing the story. They did give it to him, and it wasn't a good thing. And so I guess they called you up to quote you on what's going on out there. So what is going on out there? You know, the audience, people listening to this podcast, and honestly, everybody, right? First thing you do is you go Google it, or now you go chat GPT things. And every now and then I'm on X and I come and look at the information doesn't seem to be accurate. A lot of misinformation, a lot of dangerous information. I see patients that go to male clinics, and I'm like, I don't know that this is right? So I don't know that they needed it. They were, let's say, I don't know, their testosterone was at 500, 550. They would load them up even more because, of course, more is better, and that's not always the case. Sometimes they give aromatase inhibitors. So I'm interested in your thoughts on that, because I am not a fan of aromatase inhibitors, and I think that men need estradiol and estrogen relative to amount of testosterone. So it's all about the ratio. Of course, estrogen will go up when you do TRT. Not always, probably, but I see it often. But that doesn't mean it is a bad thing. Again, we'll have a lot to talk about. So let's start with this. What's happening out there? What are you seeing from a social media perspective? And then maybe we can move on to some of these male clinics, because I know you've done some research around that.
Yeah, so I think this is becoming a more and more prominent discussion and topic in terms of who needs testosterone, who should be getting testosterone, and understanding the risks and benefits of it. And I did my training in University of Miami, and I finished my residency in 2021. I did my fellowship at Northwestern. And even in residency, starting right around COVID, we saw this spike in the direct-to-consumer market where a lot of things that were controlled substances, even testosterone, were now allowed to be given in a more telemedicine format. And that really opened up the space for direct-to-consumer testosterone replacement therapy. Now, being in Miami and South Florida at the time, I was very familiar with men's health brick and mortar clinics that were providing care for people. And it's still a very popular thing, especially here in South Florida. These walk-in clinics, you get evaluated, they give you tea, they give you trimix injections into your penis. I can't tell you how many times I've done priapisms for guys in ERs down here in South Florida who went to these men's health clinics.
Describe priapism for the folks.
So priapism is an erection that lasts longer than 4 hours.
Is that the magic number, 4 hours?
4 hours.
Is it 4 hours?
Yeah, it's 4 hours. And pretty much, when you get an erection, normally it is a compartment syndrome of your penis, right? The blood is trapped in your penis, but you have the ability, once you achieve orgasm, the vessels relax and the blood leaves your penis. But in certain situations, you can develop priapism, and sometimes these stronger medications. I don't think it's really possible with Viagra or Cialis unless you're taking like the gas station pills that have 1,000x the normal dosage, but you can do an injection into your penis. And in general, it's safe, right? I give it to my patients all the time, but if you're not educated on it, or you're just given a medication and injected it and say go, it can create such a strong erection that the blood is not able to actually leave your penis even when you orgasm. And a compartment syndrome is like taking a rubber band and tying off your finger. Eventually, the blood is going to get stagnant. You don't get new blood to your organ, and it can die.
It's a heart attack to the penis, right?
That's a good way of describing, yes, a heart attack to the penis. And time is actually of the essence, right? Ironically, getting an erection that lasts longer than 4 hours, the longer it goes, the more likely you'll never have an erection again. So, obviously that was something I started seeing back then, but, once again, that was the original progression of the men's health clinic, where you would go in brick and mortar. These things had now developed into direct to consumer with the rise of these things in telemedicine and direct to consumer care since COVID. Now, I want to start off this conversation by really giving a stance that I think people may be surprised about. I am not against direct to consumer. I'm actually a fan of direct to consumer care. I think that there are a lot of benefits in the men's health space, right? A lot of guys are embarrassed to talk about their sexual health issues or address their low energy, their low libido. So they don't want to sit in an office. They don't want to deal with admitting to other people around them that they have an issue. So telemedicine's a great way for guys to get care they need. Not everyone lives in a city. Not everyone lives in a place where they actually have access to a doctor that's willing to prescribe these things. So I think in general, we have to understand that there are benefits. I'm not saying we need to end direct to consumer by any means. We don't. But I'm here to also give you a story in which we have to understand that there are negative things. And you as a patient, you're listening to this podcast because you want to be educated. You want to learn. And Geo and we all agree. I encourage my patients to educate themselves. I want you to learn. I want you to read about these things because it's your body, your health. You need to understand what you're doing to it.
Yeah, be an advocate for yourself. Yeah,
absolutely. And so when I started going to Northwestern, we started seeing, I do a lot of male infertility as well. We started seeing a progression or an increase in guys really who were coming in usually below the age of 35 with infertility who had been on TRT. And they were not educated on the risks of testosterone replacement therapy, the biggest one being infertility. When you take testosterone, it signals to your pituitary that you are making enough testosterone. So it shuts off the signal to your testicles, which is LH, luteinizing hormone, the hormone your brain makes, tells your pituitary makes, tells your testicles to make testosterone, and FSH, follicle stimulating hormone, the hormone your brain makes, tells your testicles to make sperm. They shut off, so your testicles can shrink, they atrophy, and then they can no longer make sperm. In fact, after about only 4 months of taking testosterone replacement therapy, about 65% of men no longer are making sperm in their ejaculate. So it's quite a potent potential sterility thing. And we were starting to see enough of these guys who were not being educated on it. They were getting these things from men's health clinics, direct to consumer, that we started to make a decision to investigate that. Now, obviously, part of this goes to social media. We also, at the same time, started investigating how people were gaining access to these things and this information. And we did a big study looking at men's health information on TikTok and Instagram. And we found we looked at men's health topics, Peyronie's disease, testosterone replacement therapy, fertility, vasectomy, semen retention, to name a few. And we found that the information was grossly inaccurate and mostly not given by any healthcare providers. Okay. Most of it was by people, personal accounts, businesses promoting interventions. And a lot of that was testosterone. Having this big picture, we kind of wanted to know what the landscape of the direct to consumer testosterone replacement therapy business was. And so what we did is we created a secret shopper, and that's why I was interviewed for the Scientific American. And what we did was I personally pretended to be a man with low testosterone. We identified 7 clinics or companies that provided care across all 50 states through telemedicine. And I applied to be a patient.
Are they going to remain nameless?
I will never tell anyone. I've had the Wall Street Journal ask. I've had the New York Times ask. I'm never telling anyone.
I need spunky material. That helps with the podcast and things, man. All right.
That was the agreement that we all made. No one's going to know except for the authors. But, 7 companies that provided care across all 50 states. I pretended at the time I was a 34-year-old man. We had a script that I used for every single one. I was a 34-year-old man who had a wife I had signs and symptoms of low testosterone, erectile dysfunction, low energy, low libido, couldn't get muscle gains at the gym anymore. But I did
at 34 with the story 34. Was 34 with a wife and kids?
No kids, but I said I wanted to have kids.
Oh, you wanted
that
to have
I
kids.
wanted to have
That's
kids.
Part of the story. Okay.
And I was very clear I wanted to have kids in the script. I got blood work and I got a full hormone panel, including things I usually don't get. My testosterone level, not to brag, it was 675. My free T was completely normal. And
avatar you or you?
No, this is me. I got
you gave them your real
I did numbers. My real blood work. And we were all joking around. Thank God I had good testosterone levels, right? Because otherwise the study's already done. But, 675.
That's right.
But 675 for our listeners, truthfully, is above, like, even some people would argue, a therapeutic goal. I think it's in therapeutic goal, right? There's no question about it. I am not a good candidate based off of my testosterone levels alone for testosterone replacement therapy. Now, add in the fact that I wanted to have children in the future should also be a contraindication that to give me testosterone replacement therapy. Now, having said that, 6 of the 7 companies offered me testosterone replacement.
6 out of 7.
6 of the 7.
Based on what?
Based off of my symptoms, I guess. Only 50% of them counseled me on infertility being a risk factor for taking testosterone. So when you look at that's pretty damn concerning. I asked questions. I was like, okay, so what's the goal? What's our goal testosterone here? Most of them did not have a true goal. Some of them said above 1,000. Some of them said, we're going to keep giving you increase your dosage until you feel better. So, these are not great things to hear when you are trying to treat someone for low testosterone.
Did your blood panel show bioavailable free testosterone?
Everything was normal. My levels are published. If you go look at the paper, you can look at every single one of my levels, which is pretty cool. So I have no shame. You can look at every single one of my labs. Okay. It's in a supplement. So you could look at it and criticize it all you want.
We're going to have to retest you continuously until they're really down and low, after like 5 nights of 5 sleepless nights or something, and then test you and republish that or something.
Yeah. But so like, I think that one thing that we need to learn from this, and once again, having even experienced this myself, I've already told you, I am not against direct to consumer care. I want it to be clear that I'm sure they do treat a lot of people who need it, but you also are empowered here. you have to ask the right questions, right? If you're seeing these ads, which I see all the time on all the social medias, and I'm sure, Geo, you do too. Hey, you come in, you get a blood test, and we just start you on T. That's not how these things should work, okay?
Yeah.
Right? Like it's called testosterone replacement therapy. We are not optimizing your testosterone. We are actually trying to treat a disorder or a disease, right? Having normal testosterone, there's no data showing that giving someone with testosterone more testosterone has any better outcomes. It doesn't show, or negative outcomes. We just don't know. And, everything that we're trying to do, we're trying to treat people who are actually suffering with low testosterone. Now, I think that's hard for a lot of people to understand because they don't understand the necessarily implications of these things, right? I think a lot of people don't understand. Once you're on testosterone, you're on it for life, pretty much. That's how I tell my patients, right? Going back to what we talked about, this idea of taking exogenous testosterone shuts off your testicles. The longer you're on it, the harder it is to come off because your testicles stop functioning. So there are long-term implications for these things, including fertility. If you're at supratherapeutic levels, and you've talked about this on this podcast, that's when you're talking about real risks, right? There's good data on these roid rage, behavioral, high risk things. These are only really seen. I don't believe in roid rage at real TRT levels. I don't think it's real. But when you are at super therapeutic levels, like over 1,000 persistently, 2,000, which people blast off to, yeah, I think that there is data showing you're at higher risk tolerance. You have some potential psychiatric issues develop. You have the back knee, you have acne, you have heart problems, stroke problems. That's where we're talking about real risk. And if you're going to a place saying that they're going to blast you off until you feel better, you probably are putting yourself at some of these risks.
Now, the clinic that said you're not a good candidate, what was that conversation like? It was as simple as that, we don't think you need testosterone, so we're not sending it to you. You've been taking care of your health, regular checkups, staying active, trying to do all the right things, but lately you've noticed something's changed. Maybe you're more tired than usual, your motivation dropped, or your strength and stamina just aren't what they used to be. These all can be signs of low testosterone, a condition that affects nearly 1 in 3 men in the United States. Kaisertrex is an FDA-approved oral testosterone replacement therapy that helps restore testosterone levels back to normal. It's not an injection or a messy gel, just a simple twice daily pill that fits easily into your routine. Find out where you stand. Order a testing kit today at kaisertrex.com/testing-kit. or look at the link below in the show notes. By prescription only, Kaisertrex is a controlled substance and can be a target of abuse. Kaisertrex is not for use in pregnant women or men with prostate or breast cancer. Safety and efficacy in those younger than 18 is not known. Tell your doctor about all medications and conditions. Serious side effects could include increased blood pressure, worsening prostate problems, increased risk of prostate cancer, blood clots in legs or lungs, liver problems, enlarged or painful breasts, and breathing problems while you sleep. Common side effects include swelling of the ankles, feet, or body, increased red blood cell count, and increased PSA levels. PSA is a test used to detect prostate cancer. Report these symptoms to your doctor. Call your doctor to learn more about Kaisertrex. For questions or information, visit www.kaisertrex.com or call 1-833-949-5040.
So the conversation was a civil one, right? It was like, hey, listen, you don't meet our criteria to have testosterone replacement therapy. We acknowledge that you have symptoms here. We can offer you X, Y, Z as an option, right?
One, it was like 3, 4, 5% of all clinics might be doing the right thing. And, now the other clinics so after they said they gave you the infertility disclaimer and all these things, then they said it was as simple as, yep, considering that what was that? I mean, it should be an awkward conversation. You're at 675, everything's, we will still send you testosterone. Like, how did that,
no, it was like,
what was that conversation like?
So the conversation was basically, okay, man, we think you're a good candidate. We'll send over, they email you the options. They say, just let us know which one you want and we'll send it over. I mean, that's how it goes.
Let us know which one you want.
Yeah.
And did you go back to them after you concluded on the study and say, guys, you were studied, we're not going to name you?
Absolutely not. Absolutely not.
But no,
I don't think that there's a benefit to that for me. I don't think there's a benefit
For
to them.
So like, hey,
who am I talking to
Yeah.
there? Like that. I'm not going to talk to the higher ups. I don't want to,
Yeah.
It's a great question. I just didn't feel compelled to do that. I mean,
Yeah, I'm not reporting you or telling the media and the news. I'm just letting you know that,
But I think, I think it's so weird because I did that study in 2023, I think already now. And only in the last year, it's really picked up traction. I think it's just because of so much interest in the space with this idea of optimization. Now, I don't know. How do you feel about the word optimization? Because I feel very conflicted about it.
Tell me more.
I think that it is such a sexy word that is so overutilized on social media by people who most of the time don't have any medical background or true medical knowledge to gain people's attention or garner people's attention or get new patients who probably don't have real health issues, right? Because I cannot give you a true definition of how I optimize your hormones. I don't know what an optimized hormone level is. I know I can treat you if you have if you have an issue with your hormone levels, if you are diagnosed with hypogonadism, but I don't know how to say this is your most optimal thing. Now, you've come on my podcast and we've talked about, supplements, and I believe in them now. I recommend them now after talking with you. That is the way when someone comes into me, I say, listen, I'm not going to give you tea. If you want to try to really optimize yourself however you define that, I offer lifestyle things, right? I offer better sleep. I check them for sleep apnea. I offer them exercise recommendations, pelvic floor PT. We're talking about other physical therapy, diet. I tell them to go see a dietitian. I offer them supplementation recommendations. But other than that, I don't think that this idea of I need to take more tea to optimize my health, I don't know if that really exists. I'm not saying it's right or wrong. I just don't know I think there are situations where it's a correct thing to do, but I also don't know if it's for everyone. I think we all want to be better, but I think the word optimization is abused. What are your thoughts?
That's a great point. My thoughts on it, man, I don't know, because I think I've used it. And now this is why I like having conversations with people like you, because I don't mind. And actually, it's very important for me to take a close look at how I do things. I always want to do that. It is a loose word, and it could be just a marketing word. And what's optimization for you is different than what's optimization for me. Like, I don't want to be you and you don't want to be me. As long as we can, certain check marks, right? Are we sexually healthy? Again, even that is whatever that means for you, right?
Correct.
Check. Are we taking care of business? Check. I wonder with this whole idea of toxic masculinity, I don't want toxic masculinity. So I don't want to have my testosterone so high that I'm enraged all the time and kind of talking back to my wife and not having patience and things like that. Now, Robert Sapolsky, who is a evolutionary PhD from Stanford, I want to say, has written on this. He's looked at animals and monkeys on testosterone levels. And his conclusion is that, higher testosterone doesn't make you an a-hole. You become more of who you actually are. So if you're already not a nice person, narcissistic behavior, you're going to be more of that.
I
if you're
agree
aggressive,
with that 100%.
But if you're a kind person and you like to give and donate and think, you're going to donate even more. You're going to be even kinder than with more testosterone in cases where it's needed. So yeah, optimization, you got me thinking on that. I think that there's a lot of useless words out there, and not to completely digress, but I have children and a few of them are in their 20s, and it's like, well, I just want to be happy. I'm like, the happiness, what does happy mean?
Agreed.
Happiness for you is different. Happiness for me. Happiness for me is actually how resilient I am to deal with adversity. That makes me happy. I want to be resilient to deal with day-to-day adversity, right? Everybody feel the more it's not, hey, yay. That's not happy for me. In fact, I know for sure that if you go to a party and that person that is trying to be the life of the party I've gone back with those people to their homes, and they're not happy people, in fact, right? They're the unhappiest people. No, I want even keel. I want, be resilient and deal
consistency.
with consistency, deal with daily challenges that we all have. I want those tools. And the more of those tools that I have, the happier I am. You may have a different definition. Optimization, the same thing.
I think you're right. Listen, I think it comes down to the word, how it's used, right? Because I think I encourage people, if you want to optimize, improve your health, come see a doctor. But if like you're being told that everything can be optimized more and more, I think you're getting right. It's just one of these things.
Buzzwords.
It's a buzzword where I can't tell everyone, right? When we treat people, we have metrics that we can use for if you have an issue. Optimization is really a subjective matter. And that's why it can really benefit people who don't really know what the fuck they're doing. Sorry.
Yeah, no, that's completely, beep. That's completely fine. So let me ask you this. Is there any case, you as an expert, you see a lot of these guys, where the profile that you gave to these clinics, where they would be a candidate for testosterone under any circumstances? So everything looks normal, but they're still complaining about, ED and all these other things. Of course, ED, there's so many factors. Look, first question, right? Do you like your girlfriend or your wife? Do you actually like her?
Always.
Right? Or him in some circumstance. Do you like your partner at all? Right? Because it doesn't matter how high your testosterone is and how optimal you are in that sense. It may not happen. So are there any circumstances with the profile that you gave to these clinics where you would think they are a good candidate?
So I think this is a really important question. And this is how one thing that I also think we have to understand about these direct to consumer situations. And, they are, and even with the ED ones, right, they're able to provide you with a solution, but they're not able to get to the source of the problem, right? So listen, I give Viagra Cialis all day, every day. I give testosterone all day, every day. But I'm able to sit down with you and say, hey, maybe this is the reason why. This is the reason why. I diagnose diabetes, high blood pressure, coronary artery disease all day, every day. The TRT places, or the direct to consumer, they're not. It's not their job. And that's for better or worse, right? So I can't tell you how many people started their care there. Right.
I'll say it. It's for worse. Okay. You got to get a complete picture. Right. Of the patient. How long did they spend with you, Justin?
It varied. I mean, it could be, I can't remember. It was too many years. It was 2 years ago. I would say from 5 minutes to 25 minutes.
5 to 25 minutes.
Yeah.
Average 15 minutes?
Probably around that, which is a standard
average
visit.
for anybody.
Let's be honest. That's a standard visit. So there's nothing wrong with that. There's nothing wrong with that.
All the information.
Yeah. But, and this goes back to your question. Someone comes into my office, and this happens all the time. Testosterone is 675. They feel like crap. They're like, I just don't have good energy. Their levels are normal. Their free T is normal. Their bioavailable is normal. Their SHBG is normal. Everything's normal. What am I telling these guys, right? Well, I'm going to quote Mo Cara again, because I think he's the master. He's like, your libido, your energy, like the way that I look at it is there's 3 things that really impact your libido, right? Sleep. I ask them all about their sleep. Most of these guys are not sleeping well. You can still have sleep apnea, or they have some kind of job where they're doing shift work. They're just not having normal hours or not normal sleep, or they have kids that are, people, you just can't sleep sometimes, right? 2 is testosterone. I say we've already ruled that one out. That's not the issue. And then 3 is mental health, right? Stress, anxiety, depression, medications that, treat these things, unfortunately can compromise these things. I saw a guy yesterday. He said about 2 years ago, all of a sudden, nothing has been changing in my life. My libido just dropped to the floor. My erections dropped to the floor. And I kept asking questions. I finally got to medications. I go, I'm looking through his meds and I go, oh, it says you're on Lexapro. When did you start that? He's like, oh, about 2 years ago. And I'm like, why? He's like, well, I was anxious. I'm not anxious anymore. I feel great. I was like, so you're saying your stuff his testosterone was like 750. He was a healthy guy otherwise. And I go, so you're saying that all these things started about 2 years ago, but you said you started taking this medication 2 years ago. Is that right? He's like, yeah, I never thought about it. So what I do, I said, you got to go talk to your psychiatrist. So he's going to go talk to his psychiatrist because there's other medications that he can try to fix this problem. But I don't think it was his testosterone. And the truth is, and guys don't want to hear this because the way that we're pushed this message online is that testosterone's always the issue, where really it can be.
It can be, but
it can be, but it's not always the
but
issue.
you think the numbers will correlate with the symptoms to some degree? I'm not saying below 300, which is the range is between 300 and 1,000 or whatever.
Right.
On the labs. I'm not saying it has to be below 300, but even we may argue or not argue, agree that sometimes 350 is very low for some men.
Oh, yeah.
So even when the numbers are not below, let's say, whatever, 350, again, like your case, you think that it may be a testosterone issue, or again, because when, I guess what I'm asking is, when do they not correlate, right? The numbers correlate.
What's the threshold for it not correlating?
Yeah, with the symptom presentation.
I think this is a very hard answer to give, and I don't think there is a correct answer. I think that after doing it for a while, you kind of have a gestalt about these things. And we were talking before we went on, like, I think over my progression, I'll be completely honest, I think I've become a little bit looser for how I diagnose low testosterone. And we're talking about these direct-to-consumer companies, but, you know, it's very hard for me sometimes to rationalize that if our goal is to treat someone with low testosterone is at least 450 to 600, how am I telling someone who's 300 that their testosterone is low, but if they're 350 or 370 that it's not, if we're making a boost to get them to a different level? So, you know, I don't have an answer for that, right? And this was a guideline thing, right? And so the guidelines are guidelines. They're not law, right? And that's one thing you have to understand. And when you look to someone, I see guys all the time, their testosterone's 400, 389, and they feel fine. They're not complaining. They have no signs or symptoms. I say, okay, you're good. Like, do you want to do it? They're like, no, I'm good. Right. So, you know, it goes both ways, right? The diagnosis is you have to have the signs and symptoms of low testosterone, and you have to have a low testosterone. Now, defining what low testosterone is, you've had many people on, and I'm sure a lot of them will say they'll give you a normal, if you have a normal T, but your free T is low, they're going to give you testosterone. I do that all the time. I think it's true. So there is different ways of looking at that. And I think that there has to be a gestalt. There is an art to these things. Medicine is a science. It is, you know, it's not always black and white. And so, you know, fortunately, when I was doing my direct to consumer, I think it was very clear that I was very lucky that my levels were the way they were, that it was black and white. We made it so that it was black and white. But I think in reality, you know, you have to sit down with your patient. You as a patient have to sit down with your provider. You have to really have a conversation of what your goals are, what you think, you know, is going on with your labs, and, you know, whether doing something is right for you. There's other options too, right? I can't tell you how many men who are hypogonadal don't want to go on TRT because they don't like the idea of permanence. What do? I put them on Clomid. And Clomid is, or HCG. Right. And they just like the idea of naturally creating more testosterone, right? Yeah. So, you know, that's another thing that I always bring up, because like, even though you're taking Clomid or HCG for the rest of your life, you can stop it and go back to where you were before. Typically, that's not the case with TRT the longer you're on it. And people like the idea of making your own testosterone, which is what Clomid and HCG do. They trick your testicle into making more endogenous testosterone in your body. So people like that idea. And I always offer that as an option to any patient who comes in.
Fascinating. So buyer beware, right? Buyer beware. More is not better. Educate yourself. If you are a self-health advocate, which is what we call you on this podcast and in this community, educate yourself. And if you're having low libido and or erectile problems, it is not always related to low testosterone. I think those are the key takeaways, right, Justin, here?
Yeah, I would say, and I think there's, just to kind of bring it in with, like, if you as a patient are going to a direct to consumer, or you're trying to learn whether the person that you are seeing knows what they're doing, right? You want to ask a couple questions, especially when you're going to a direct to consumer TRT or a men's health clinic. Once again, there's a lot of good ones out there. There's bad players. There's good players.
There's
We
not
just
a lot
want to
of
be
good
aware.
ones based on your study.
Well,
Not based on your study. If that's a representation of what's going on around the country, there's not a lot
who
of good
knows
ones.
now? Maybe it's changed, but probably not. But you're right. You're right. You know, but there is a lesson to be learned. Is like you're going to go in, but people still use them. And I was going to bring up this study quickly. But let me I'll bring up a study after we just conclude this concept. Is that ask yourself, what am I going in there? What am I going in there for? Am I going in to learn about my health? Like just get labs, learn whether I have low testosterone. Am I looking for a treatment? What are my treatment options? And then the real question is, who is giving me this, right? Who am I talking to? Ask who they are, what their background is, how long they've been doing this. And then you
only have 15 minutes. Justin.
Yeah. Well,
that's 7 minutes by itself asking all those questions.
Yeah.
You know, this is
right.
actually, I'm kind of tongue in cheek, but it's true. It's like,
it's true.
You have 15 minutes to ask.
I will tell you, they did tell me. I asked every single person. I was able to achieve it in 15 minutes because I asked these questions. That's why I'm telling you. Because remember,
you're prepared. You are a physician. You know what questions to ask. You're not,
that's why I'm telling your listeners what to
Yeah, right. Exactly. That's true. But you know, how they look. Part of the issue, let me put myself into the patient's shoes for a second.
Please.
And I, you know, I'm listening to people. I read all the comments, and you know, I get emails. You know, part of the issues why they will go to a men's health clinic is because is easier, it's faster, and I don't know who they're speaking with on the other side because I have not called these places. But you know, patients are having trust issues with physicians. Your wait time is months. You know, to make an appointment with you, it takes about 3 months. I don't want to wait 3 months. I already have trust issues with my physicians. I mean, that's an ongoing theme that I've seen with
1,000%.
So I can see why the attraction to call one of these places and doing it with them, and you know, going through it with them. What are your thoughts on that?
So this was exactly what I was going to talk about next. You read my mind here because this was another thing that interests me. Understanding what brings people to the treatments that they choose. And so what we did is we actually did 2 studies. One of them is published. One of them is an abstract that we're writing the manuscript for now. But we did 2 studies. We actually surveyed men under the age of 40, 18 to 40 years old. One, we asked them about their erections. We gave them how to complete a shim or an IIEF to see if they actually had, you know, per the study. It's a validated survey for erectile dysfunction.
If you've been to your urology office, you filled one of these out.
Pretty much filled one out. Yeah. Right. So we had them fill that out. We asked them some questions, where they got their medications, what determined where they got their medications, whether they were counseled on everything. And what we found out is that of the men under the age of 40, 57% of them actually met criteria of having erectile dysfunction, which is pretty damn high. 39% of them had used erectile dysfunction medications in the past. And we asked them, you know, where they were getting their medications. The most common source was actually primary care providers, about 47%, but 31.7% were direct to consumer. That was the second most. Yeah. And then we asked, this was really interesting and highlights how valuable direct to consumer and why it's valuable, is we asked what were the key considerations in how they wanted to obtain these medications. And number one was privacy. Above cost, above convenience, privacy was the most important consideration on how to get their erectile dysfunction medications. So if you want to talk about a study highlighting the stigmas of men's health that still exist today, that is it. Guys are willing to pay more so that they don't have, and they're willing to be inconvenienced as long as no one knows that they have to get these medications. So that's the first one. That one's a manuscript. It's out. It's published. The second one that we're about to publish, we're submitting now, but it's been presented at conferences. Was we also surveyed men, again, under the age of 40. We asked them whether they've taken testosterone, whether they've thought about taking testosterone, how they were taking it, where they were taking it, and what they were using, right? And we found that actually, I was surprised. Only about 13.5% said that they had used testosterone in the past, which is in line. And this was done within the last year. This is in line with data from, I think, 2018, which said around 12.9% of men under the age of 40 were taking testosterone, which I'm surprised about. I really thought it was going to be higher based off of everything that we're seeing. But, nearly 40% of participants did consider taking testosterone. And those that did take testosterone, 16.7% of them lacked any diagnosis of low testosterone. So there was an off-label use, right? So who were they getting it from? Urologists actually were the most common, 28.3%. Primary care physicians, 22%. And then, but about one quarter, 25% of them, of users had reported obtaining testosterone from direct-to-consumer platforms at some point in their treatment course. So it is becoming quite prevalent, right? And then when we're talking about other things that they were using, 57.4% of these testosterone users were using SARMs, selective androgen receptor modulators, which is very concerning because, that is illegal. A SARM is these medications that are actually not legal. You have to buy them online as chemical experimental drugs that they were believed to be designed similar to Clomid. Clomid is a SERM where they act and support the androgenic receptors of your body to have theoretically only create increased muscle mass and bone mass, but they haven't been shown to be very effective. And there's no pure creation of it right now because there's no pharmaceuticals that are making it. You buy it online as an experimental drug and people are taking it, which is very concerning.
For clarity purposes, clomiphene is SERM,
Is a SERM.
S-E-R.
S-E-R-M.
And
Clomid
you're
is
talking
safe.
about
You're
talking about SARM, S-A-R.
S-A-R-M.
Yeah.
There's one called like Ostarine is a very popular one. And they used to sell it at GNC. Actually, they don't anymore.
Yeah.
When we were talking about, the most important factors influencing these patients was safety, ironically, and then privacy, followed by cost and convenience. So once again, privacy over cost and convenience for getting these kinds of medications.
Why is privacy an issue? If I go see you, is it not a private? It
is an issue. And I'll tell you why. Guys going into an office are seeing other people. They don't want to sit and wait in a public space where they're pretty much announcing to whoever may be there that they have a problem. People make their own assumptions, right? We all think we're more in our heads than we would like to be, right? Someone's staring at me, they know this, they know that. And that's just the human condition, right? But you don't have that issue. If I just hop on the phone call or I hop on my camera in my room, no one knows I have an issue, right? I don't have to announce to my work that I have to go to the doctor, right? People are embarrassed to talk about that, right? Guys don't want to say, I got to take off a little bit of time. I got to go to the doctor. Oh, what kind of doctor? People end up asking, even though they shouldn't, what kind of doctor? Oh, I got to go see a urologist. So, there is a privacy issue that is being addressed by direct to consumer. To
be clear for the listener and the viewer, it's not that if you go to see a legitimate physician like Dr. Dubin, that there's no the people are going to know about your business because there's HIPAA laws and rules that's not the case. It's more about, being in a setting with other men, that might be uncomfortable, though they may not know you, or they may, hey, Geo, what are you doing here? Like the guy said, Geo, what are you doing here? Oh,
it's happened. It's happened in my house.
So we have the same issue. You're in, okay, let's talk. No, I don't want anybody.
Some people don't mind that conversation. Some people really mind that conversation.
Right. So that's the issue here. That
it is the idea that they are announcing by actually physically being in an office. You're right. I have patients come in, they go, hey, I had a referral from my friend who sees you. This person's this person. I say, That's great. Thank you. I can't confirm that I see them. Right. That's literally my response because of exactly what you're saying. Like, I don't even want to tell that person that I saw their patient because that is HIPAA, right?
Yeah.
I literally say, congratulations. That's great. I love to hear that. I love to hear they're happy, but I can't confirm that I see that patient. Right.
Right.
That's how serious I kind of take it sometimes, because I do think that sometimes guys don't want to know.
So what are we going to do about it? What are you going to do about it? I mean, so here you are, you're saying, hey, it's a huge problem because if you have normal testosterone or even optimal testosterone, they may still prescribe because I guess it's a business and they need to run their business. But it may be harmful because you know, particularly if the person doesn't need testosterone. At the same time, it sounds like you studied it and are understanding why they would do a direct to consumer. So what is one to do, Dr. Dubin?
I think we can all exist. And I think that this is really part of it, right? I have a lot of patients who like to use the ED prescribers at home. They like the chewables, they like the troches. I can get those, but they like them the way that they like it. And so they come in, they say, I'll use that script. I still assess their health. I still do what I need to do. I have guys who, say, hey, I want to get the TRT from this place. I like the pricing. I like whatever. I still want to see you. Okay, I'm going to do it. Right. But I also think that I've seen so many guys, and this is where one of the things that I think the direct to consumer is good at, it is a gateway to men's health. Never have we been more comfortable, despite all the stigmas I talked about, never have we been more comfortable. Have guys been more comfortable talking about their erections, their low testosterone, because these companies are blasting ads all the time, everywhere, destigmatizing the conversation. And I thank them for that.
Yeah.
And I see them as a gateway into the men's health for a lot of people. I can't tell you how many people say, hey, I went through this company, I went through that company. I'm not really, I want to learn more. I want to learn more about what's going on in my body. And they come to you and they talk with you. And maybe they never would have gotten to that point if they didn't try those other things. So I think that there is a bridge that is created. I also think when we look at all of these things, we as providers have to meet our patients where it is. I do so much telemedicine. I do telemedicine because I understand what patients want to do and what they feel more comfortable doing. And I have no problem. Obviously, there's certain things, I think I'm always happy to start with a telemedicine, but there's sometimes I need to do an exam and I tell them, but there's a level of trust eventually that comes that you can say, hey, listen, in order to really investigate this thing, I need to do an exam on you. Can you come in? And I think building rapport, explaining to patients, and educating people through things like this podcast that we've already discussed, right? I can investigate why things are happening and help you figure out that why and fix that why, right? I can also really kind of just be a more comprehensive center for answering the questions you have and in a way that you need them answered. And there's a great paper that was out of UCLA where they did a study. They took men who came in with erectile dysfunction. I think it was just erectile dysfunction, and they did exams on them, and they having them physically be there, they wanted to see what they were able to identify that a telemedicine couldn't. And in about 20% of these young men, they were able to diagnose something that they wouldn't have been able to diagnose had it just been a direct to consumer telemedicine visit. So you have to realize that, we are able to capture more of what's going on, and we're able to get to the heart of the matter, whether it is actually your heart, whether it's your nerves, whether it's your hormone levels.
Seriously.
Yeah. So I think that it's a great way to start, but I also think that we can work together as providers. We have to understand where our patients are and where they live and where they want to be, whether it's providing with the education here on the podcast and how to actually manage a direct to consumer company that you actually like doing and making sure you're getting good care, or, meeting them halfway and going to see a doctor while being on these things, making sure your regimen's good, which is something I do all the time, right? Patients come in, hey, I'm on this regimen. I really respect your opinion. I want to know what you would do in this situation, right? So there's
So
a lot of
you
things
believe in it, that we can all coexist. That's a very interesting.
I think we have to. I
Yeah,
think
because that boat
we have to.
that boat has sailed, right?
Correct. The boat has sailed. Like, you know, and I don't think, I'm not saying we need to regulate these things more, because I think making more regulation actually hurts probably everyone as
Yeah,
well, because
yeah,
we're ruining access to care.
right.
But we also, by, you know, hopefully things like my study, continuing to talk about these things, these companies become aware that they need to do better. Patients become aware that what they need to look for and how to get good care. But, you know, we have to live together, and because that's just the way it is now. So
Yeah.
we have to provide good information to our patients. We can hopefully continue to guide good telemedicine practice, guide good direct to consumer practice, and hopefully we'll all be better for it.
So buyer beware, right? Consumer
Always.
beware. Yeah, yeah. And if it
Always.
sounds, that was one rule of thumb with if it sounds too good to be true, it likely is, right?
I think that's usually the case.
Dr. Justin Dubin, thank you so much. You know, I'm so glad that we had this conversation, because I don't think, by the way, you come up with the most interesting studies in the world, man, as it relates to this. God, why? I mean, literally the male porn and why they get ED, that was a study. That wasn't just, clinical experience on these male clinics, wellness clinics. I mean, I don't think there's another Dr. Dubin out there doing this kind of work, I got to say.
I appreciate it. Listen, I told you, we talked before we started, what makes you curious, and you're a very curious guy, and that's why you're so successful in your podcast, and why you bring in and you ask really good questions, right? We're having this conversation just because you're interested in it, right? That's literally the only reason why we're having this conversation. But one thing for me is, I like doing research, but I like doing research that makes me think. And I try, like, in general, a lot of the things that drive me is how patients think. I want to understand how patients think more. A lot, and that everyone has their own research, right? People want to understand treatment modalities. People want to understand outcomes. They want to understand other things. I'm becoming very interested in what drives patient care, and how patients are perceiving their care,
Yeah.
and what motivates them to do these things, and how they perceive other things. That's why the porn thing, I wanted people to see that, like, they have erectile dysfunction just as much as we do. So I'm interested in the human experience to many degrees, and my
human
patient's
behavior, it
experience.
sounds like,
Yeah.
right? Like why people do what they do. You know, that's why we get along so well, because I'm super fascinated with that kind of stuff. I
Yeah.
mean, patients come to me and it's like, okay, they oftentimes they will say, you are my therapist. I don't know if you know that, but you're also my therapist. And human behavior, human psychology, fascinating to me.
It's great.
Justin, parting words, and how can people find you? And I just want to say that you are one of the best physicians that I know in the South Florida area that do. I don't know that I know every person that does male health down in South Florida, but I know a good number, and you're one of the top ones. So I want to make sure that people find you as well. So parting words, and where can people find you?
Oh, wonderful. Thank you so much. That really means a lot. So I think the story here really is, when it comes to your health, you really need to be thoughtful. You need to be thoughtful about what your goal of your treatments are, what your goal of your future is, right? Because one thing we talked about is fertility, and you have to ask the right questions before doing anything. And being inquisitive is okay. And if someone's mad at you for asking questions, then you should probably go find someone else, because you really should be asking questions. This is your health, this is your body, and I want you to make sure that you're asking the right questions and understanding the treatment risks and benefits, because there's a lot of great players, there's a lot of bad players, especially in the testosterone space. And I'm hoping that through this conversation today, you learned a little bit about how to guide yourself in that journey of improving yourself, and especially if you're someone who needs some testosterone replacement therapy.
What are your top 3 or 5 questions, just to summarize again? What would they be?
I think it would be like, what is my goal of what I'm trying to do with this direct to consumer? What is it? Just learning about my health through labs? Is it, trying to actually get therapy treatment if I need it? The next question is, who am I talking to? What is their background? How long have they been doing this? Do they have a good grasp of this knowledge? Obviously, sometimes it's hard, but you can, direct to consumer, and this is just a quick aside, direct to consumer, you never know who you're talking to for the most part until that moment. It's very different than if you go to a doctor. You can Google the hell out of doctor. By the time someone sees me, they know where I live. Like, they could probably find my address where I live, right? You can't really do that because you don't know who you're talking to in direct to consumer. So you can always take down their name and do a little bit of research afterwards. But in the moment, you probably don't know a lot of times. So just a quick aside, which is always interesting, right? That doesn't mean it's bad. Doesn't mean it's good. It's just a fact. And then 3 is, what are the risks and benefits of what I'm going to be doing if I decide to do this, right? And you don't need to make a decision that day, right? You can make a decision after you study, after you ask questions. And the last thing is, if I'm unsure, who can I talk to next, right?
Okay.
Go find a urologist, go find an endocrinologist, go talk to a primary, go talk to Geo. There's a lot of really smart people out there who know the space, who can provide you good information, and getting a second opinion is never a bad thing.
Excellent. And so how can people find you, Justin?
I'm a urologist in South Florida at Memorial Healthcare Center down in Broward. I also have a podcast, the Man Up Podcast.
That's
Geo
right.
has been on it. We'll have to have him on again soon, actually. And so the Man Up Pod, it's on YouTube, it's on X, TikTok, and Instagram. You can find me on YouTube, or not on YouTube, on Instagram and Twitter or X at Justin Dubin MD. And always a pleasure coming on. Just an awesome show. And thanks for doing what you do, man. You're helping a lot of people.
I appreciate you, man. Thanks so much. Thanks, everyone, for tuning in, viewing on YouTube, or just tuning in on your podcast platform. As you know, we're always bringing the goods here. We get the best of the best to bring their expert opinion, advice, experience, so that you can be a self-health advocate and advocate for yourself and ask better questions, think differently about your health, and have better conversations with your physician. Thanks so much for tuning in. Don't forget to like, comment, 5 stars, only if I deserve it, if it's quite all right. Dr. Geo here signing off. I'll talk to you next time. Much love. Be well.
We hope you enjoyed this episode. You will continue to receive powerful interviews and insights to support your prostate health journey. For those who want to dive deeper, our exclusive membership offers even more.
If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.